We all came here to hear the wonderful Dr. Hammon, who is a Los Alamos native. She's born and raised, who has lots of friends and family in this room right now, and I think that's absolutely fabulous. She's extremely generous with her time and her resources this evening, and we want to thank her very much for her generosity and her gift of being here in Los Alamos to share her passion and her talents and her knowledge with us when it comes to head and neck cancer. So, Rebecca, I want to just welcome you from the bottom of my heart for being here as a board member and a daughter of many in my family with cancer. My heart goes out, and thank you very much for being here. So I want to tell you a few things about Rebecca, but to make it a little bit more fun, I'm going to have Rebecca come on up here for a moment. Give her a hand, everybody. So, Dr. Hammon, please tell us about your PAC-8 experience real quick. That's so fun.
I'm trying to remember. I think it was 7th grade, and I worked in PAC-8. I have a very clear memory of the holiday season, being sent out for man-on-the-street interviews with everyone doing their Christmas shopping, and stopping people to ask if they could name Santa's reindeer. Included Dave Fox at CB Fox. I don't think he got all of the reindeer names, but he was pretty close. So.
What a fun memory. That is so cool. So share with us one more Los Alamos memory that you have that you...
Oh, man. I played tennis for the high school, so probably a lot of you know that. Varsity tennis for 4 years, had a lot of memorable matches, but probably the most memorable was my junior year, so this was 2000. And the night before we left for the state tournament, we evacuated our house in the middle of the night from the Cerro Grande fire. I played doubles, and my doubles partner, Julie Fife, who now is living in Switzerland, actually, doing science there. I had no idea where she was. This was pre-cell phone era, and we stopped at the gas station down at Totavi, and she and her family pulled up right next to us. So I knew at least we were going to play tennis the next day.
Wow, what a great story.
Yeah.
I love that.
Yeah.
We all have a little story around the Sierra Grande fire,
Oh my goodness,
don't we?
yeah.
Oh my goodness. And so you no longer live in Los Alamos. You have graciously flown in to be here this evening. Tell us a little bit about where you are and what you're doing now.
So I did all my schooling in California. I went to Stanford for my undergraduate degree, then UCLA for medical school, with a quick stop in between back here at the lab. I worked in the biosciences division for a year. And now I am doing my otolaryngology residency, which in layman's terms is ENT, or ear, nose, and throat medicine, at the Harvard program in Boston. We're mainly based out of the Massachusetts Eye and Ear Infirmary, which is one of the only freestanding specialty hospitals left in the country. There we only take care of eye patients and ear, nose, and throat patients. I also rotate at a lot of the other big hospitals in Boston you may have heard of, the Massachusetts General Hospital, the Brigham and Women's, Beth Israel Deaconess, all of these hospitals that are on Boston Med that you see on TV. I don't think I'm in any of the episodes, but so I'm in my 4th of 5 years there. After that, I'm going to do 1 year further training in head and neck cancer surgery in particular, and then find a job. Finally. So if anyone knows of any jobs, that would be great. And that's about where I am, yeah.
Excellent. Thank you, Dr. Hammon, for that beautiful introduction. Everybody give her a round of applause. I'm going to turn the stage over to her.
Thank you. Thank you so much. So I was talking to my mom, Diane Hammon, over there, before the talk, and she was remarking on how head and neck cancer has become my passion. And I've had a lot of passions in life, but now this is it, learning more about it and taking care of head and neck cancer patients. My scientific interests include human papillomavirus-related cancer, which you will hear much about in the next hour, and clinically, raising awareness about head and neck cancer. So, you know, we're all very familiar with the efforts of the Susan G. Komen Foundation for breast cancer. You hear a lot about prostate cancer and lung cancer and all of these things that affect many, many more people than have head and neck cancers. So it's my passion really to educate everyone I can about what I see as a little bit of the neglected stepchild of the cancer world. So thank you for coming and spending an hour just to hear a little bit about it. And I hope that by the end, you find yourself knowing a little bit more about it, that you can tell your family and your friends and just raise some awareness. So this is a brief outline of what I hope to cover tonight. We'll go over some of the basics because I know not everyone is familiar with what I'm going to be speaking about. We'll talk specifically about the role of human papillomavirus in some specific types of head and neck cancer, and then some details about treatment and then prevention, which is unusual. Cancer prevention is sometimes a little bit of a nebulous topic, but luckily for head and neck cancer, there's some very specific things that we can do. So here we go with the basics. What is head and neck cancer? So technically, head and neck cancer is any cancer of the head and neck, which you can imagine encompasses a lot of different things. For what we're going to speak about tonight, we're going to specifically focus on a particular histologic subtype called squamous cell carcinoma, which I've abbreviated HNSCC through the rest of the talk, or head and neck squamous cell carcinoma. And this is a tumor that arises from the epithelium or the lining of the nose, sinuses, mouth, and throat. So this is a picture of normal oral mucosa, what you would see if you took a piece of someone's tongue and stuck it on a slide. So we have normal squamous epithelium at the top, some connective tissue, and then muscle down below. Just from far away, all you need to see about the squamous epithelium is that at the bottom, at the border between the squamous epithelium and the connective tissue, you see some darker cells. They're stained more blue. And as they rise towards the top, they get fainter. And then there's a line of keratin at the top, and this is the waterproofing of your skin. You also have it in the lining in your mouth and your throat. If we zoom in a little more, we can see a little more detail about this squamous cell epithelium. And again, you can see these darker cells at the bottom. These are the basal cells, which are the stem cells that give rise to the rest of your skin and mucosa. And they differentiate as they go towards the top. They lose their nuclei, and then this is the keratin at the very top of the layer of mucosa. So how does cancer develop in these areas? This is a schematic of cervical cancer, but cervical cancer is very, very similar to cancer of the head and neck. So we have these dividing cells at the basal layer that supply the rest of the cells as they rise towards the very surface. In normal development, this happens in a very orderly manner. In different types of dysplasia, which is abnormalities of this maturation, but without cancer yet, you just see that these cells kind of don't nicely layer at the top. There's some bulging. The cells stay bigger as they get towards the top. When there's abnormality throughout the whole thickness of the mucosa, that's carcinoma in situ, which is a cancerous lesion, but it's not invasive cancer. In the end here, we see invasive carcinoma, where the cells of the basal layer have actually now broken through the basal cell layer, through the basement membrane, and are invading into the tissue, the surrounding tissue. So this is the specific type of cancer I'm going to talk about today. There are many, many other types of cancers of the head and neck, including thyroid cancer, which is very common, cancer of the salivary glands, the nose and the sinuses, all of which are much less common. This is a picture that I thought quite nicely illustrated the normal mucosa here, where again we see those dark cells at the basal layer losing their color till you get to the keratin at the top, and squamous cell carcinoma right next to it. So here we lose all of that orderly maturation, and we have nests of cancer cells invading into the deeper layers of this tissue. This happens to be squamous cell carcinoma of the lip. So any squamous cell carcinoma you have in your body is going to look very similar to this, whether it's squamous cell carcinoma of your skin, your tongue, your throat, anywhere in the lining that you have squamous cell epithelium. So head and neck cancer for tonight is tumors arising in different anatomical subsites. And because they arise in these different subsites, you have resulting differences in tumor characteristics, treatment options, and then outcomes. Namely recurrence of the cancers and how long you live. So this is a schematic of the head and neck. The most common type of head and neck squamous cell carcinoma is in the oral cavity, which mostly includes the tongue, but also includes your cheeks, the inside of your lip, the gums, and the hard palate. Next most common is squamous cell carcinoma of the larynx. Everyone has probably seen the pictures from a long time ago, the anti-smoking campaigns with people with the breathing through the holes in their neck. That's laryngeal cancer. And third most common, cancers of the pharynx. And by the pharynx, we mean the throat. So tonight we'll be talking about the oropharynx, which is the area just behind your mouth, and the hypopharynx, which is the area basically between the oropharynx and your larynx. So in 2015, of course, we don't know exactly how many cancers are going to be diagnosed this year, but the American Cancer Society has some preliminary numbers based on trajectories. So we're looking at almost 46,000 new cases of oral cavity and pharyngeal cancer with almost 9,000 deaths. So again, in the grand scheme of things, looking at this compared to breast cancer or prostate cancer, not as big of a number, but this is not insignificant. The most important thing is that there's actually an increasing incidence of head and neck cancer of about 1.3% per year, mostly in white men. And this traditionally is a subset of the population that mostly has been experiencing decreasing rates of cancer. And the 5-year survival rate, if we take all comers with head and neck cancer, remains the same at about 60%. And this has been really for the last 40 or so years. So even with all of the advances that we've had in medical treatment, oncology treatment, new chemotherapies, better radiation, we're still at 60% 5-year survival rate. There are some important differences in the survival rate that we'll talk about in a bit. So what causes head and neck cancer? Two things. Smoking and drinking. This is traditionally the main cause of head and neck cancer. Smoking tobacco gives you a 28% increased relative risk compared to people who have never smoked. And this is even more dramatic for women, which is important. After 3 or 5 years abstinence from smoking, your rate decreases almost to baseline. So even if you've been smoking for 30 years, if you can stop now, you're really doing yourself a favor. And then second, which is a topic that's near and dear to my heart, is infection with human papillomavirus. This has been in the news a lot. There's now a vaccine available, which we'll talk about in a bit. But there is a subset of head and neck cancer that is associated with prior HPV infection. And this now really accounts for the increasing incidence that we're seeing of head and neck cancer. In new oropharyngeal cancers, so again, these are the cancers of the back of the throat, HPV infection accounts for probably more than half of new cancers in that area. And in some places, including my institution, we're looking at 85 to 90% of these new cancers are related to HPV infection. Some other important causes are much more rare, especially in this area, but chewing tobacco, also an important cause of oral cavity cancer. Chewing of betel nut that is prevalent in Southeast Asia, eating lots of preserved or salty foods, which is more common in East Asia, and then poor oral hygiene and certain occupational exposures. I was talking with my dad earlier about woodworkers and wood dust. There's a very close link with sinonasal cancer, which we won't be talking about tonight, but there are some other causes other than tobacco and alcohol and human papillomavirus. Alcohol is interesting. So in order for alcohol alone to really cause a squamous cell carcinoma in the upper aerodigestive tract, it has to be very heavy usage. And really, it's the combination of tobacco and alcohol that's the worst. They've done animal studies where they have kind of bathed the animal's mouth in alcohol, applied tobacco carcinogens, and seen that there's a multiplicative risk for these head and neck cancers. So how do we diagnose head and neck cancer? So the symptoms are not very specific. People can have persistent pain of the throat, of the ear, in the mouth, difficulty swallowing, changes in voice, or potentially even just a mass in the neck. Everyone's telling them it's a lymph node, hasn't gone away. They finally get to the right person who does a biopsy, and lo and behold, it's head and neck cancer. We diagnose it as clinicians based on that history of those things we just talked about, and then a physical examination, which really has to be a thorough examination both by palpation or feeling and touching, and visualization of all of those areas we talked about, starting from the nose and the lips all the way down to the voice box. This picture is from the Mass Eye and Ear website. That's Dr. Emmerich, who's one of my mentors, wearing the head mirror, and behind him is Rash Sethi, who's one of our junior residents. The head mirror, this is kind of a very old, traditional thing associated with physicians, and before I became an ENT, I had no idea what a head mirror was for, but it has a hole in the middle. You wear it over one eye. You have a light situated next to the patient's head that shines on the mirror. You're looking through the center, and you reflect the light into the area that you're examining, which leaves both hands free to pull things apart, to look all around in that area in the mouth. We also have some newer technology than the head mirror. Some of you may have had this done if you've ever seen someone for bad sinus disease, changes in your voice. We do these flexible fiberoptic exams. I describe it to patients as a little bit like having a piece of spaghetti you put down your nose. But you can see on this picture here, the scope is being advanced through the nose to the back of the nose. You take a 90-degree turn down, and you can look down the back of the throat to the voice box and observe all of the lining of the throat and the nose, how the vocal cords are moving, and any masses or lesions in this area. And this is a picture of what we see when we're looking down there. So this is a picture of two vocal cords. This is the epiglottis, which is the little flap of tissue that covers your larynx when you're swallowing to prevent food and liquid from going down your airway. These are the vocal cords here. The patient's front is here, spine is back here. The esophagus is not an open tube when you're not swallowing, so it's collapsed here behind the larynx. You can see this lesion on the left vocal cord, and that'd be something suspicious that we would want to biopsy. Below the vocal cords, you can see the trachea. So what does head and neck cancer look like? Well, we just saw that lesion on the vocal cord, so here's another one. Again, this would be from a flexible fiber optic exam. This is a precancerous lesion of the right vocal cord. How do we know it's precancerous? We have to biopsy it. That's not something you can tell just by looking. This is a slightly more advanced cancer on the side of the tongue. You can see this ulcerative lesion on the right side of the tongue. It's probably an early cancer, but again, we can't tell just by looking. We would be feeling that if there's a mass that's palpable with it, and we'd be looking for enlarged lymph nodes in the neck as well. And then this is a surgical specimen. This is a larynx excised from the patient. Here's the epiglottis that we saw before. The two vocal cords are right here, and this large mass right here is the cancer. So sometimes when cancers are big enough, surgery is the way to go. So we'll talk a bit about staging. I know some people in here are clinicians. So most cancer staging is done using the TNM staging system. T stands for tumor, which is the primary tumor. N stands for lymph nodes. And M is for distant metastases. Head and neck cancers are all staged according to their subsites. So I'm not going to go through all of it because that would take a whole hour, and you can look up the details on the internet, just like everything else. But we can talk about the broad overview. So for the primary site, the T stage is determined mainly by size and also invasion of adjacent structures. The nodal staging is pretty much the same for most head and neck cancers with some differences, but it's based on lymph nodes in the neck and their size, which side is involved, and how many are involved. Distant metastases is easy. It's a binary variable. Either you have them or you don't. So for example, if someone has a 3.5 centimeter tongue cancer, that makes them T3. Bilateral cervical lymph nodes, so both sides, but they're all less than 6 centimeters in size. That means they're N2C. And no distant metastases, so we would say it if a doctor is talking to another doctor, T3, N2C, M0, tongue cancer. Everyone wants to know, well, what stage is that? Well, it's stage 4, but for head and neck cancer, it's actually really easy to have stage 4 cancer. As soon as you have bilateral lymph nodes or big enough lymph nodes, you're stage 4, but that doesn't mean the cancer is not curable. So for a lot of other cancers, as soon as you hear stage 4, you start thinking the worst. Well, head and neck cancer, you really have to temper that with some more details about the cancer. So that's the basics. Any pressing questions just from that? I want to make sure we're all kind of on the same page moving forward. So now we're going to talk a little bit about the role of human papillomavirus in head and neck cancer, and I find this absolutely fascinating. So viruses are tricky things. We know they're associated with some other cancers. Most people are pretty familiar with the role of HPV in cervical cancer. There's some other rare associations with leukemias. Nasopharyngeal cancer is associated with Epstein-Barr virus, which is the virus that causes mono. But this really, the association of HPV with head and neck cancer has really only come out in the last 10 or 15 years. So this is evolving, and we're quickly learning more and more about it. So HPV is human papillomavirus. It's a non-encapsulated or non-enveloped double-stranded DNA virus, and all that means is that the virus capsid, which are the viral proteins, there's some double-stranded DNA inside, and there's no glycoprotein envelope around it. These viruses, there's about 170 different strains, and they're broadly classified into low risk and high risk, meaning the risk of cancer associated with these different strains. HPV infection is associated with some different cancers, mostly anogenital cancers, such as cervical cancer, where almost 100% of cervical cancers are caused by HPV infection. There's some rare ones that aren't, but it's almost 100%. Most anal cancers, and again, oropharyngeal cancer, this number, 70%, is probably too low. So again, our data at Mass Pioneer, we're looking at more 85 to 90%. And then some other rare cancers that we won't talk about today. You'll see HPV-16, which is one of the strains, is listed on all of those. It's highly oncogenic for reasons that we're just starting to understand. Low-risk HPV strains, such as 6 and 11, are the things that cause, such as genital warts. They can cause papillomatous lesions in the larynx. The strain that causes common warts, such as you'd get on your feet or your hands, is HPV-2, so not one of the highly oncogenic strains. So how does a virus cause cancer? I find this just so interesting. So after infection with a high-risk HPV virus, the viral genome actually inserts into the host genome. So meaning that little bit of DNA that was inside the virus is now integrated into your own DNA in that cell. Once that happens, two viral proteins, kind of creatively named E6 and E7, are finally expressed. And these proteins are what cause cancer. So the details aren't super important, but E7 blocks a protein called PRB, and E6 blocks a protein called P53. And these proteins are really important in regulating the cell cycle, or how the cell is growing in response to outside signals. So once those proteins are dysregulated, you have aberrant proliferation, extended proliferation. Some other things happen in the cell that cause it to have an indefinite lifespan, meaning it no longer dies when it's supposed to. And all of that together creates genomic instability and leads to cellular transformation, which really is just a fancy term for saying a normal cell is now a cancer cell because it's growing in an unregulated way. So based on that, it seems a little clear that HPV-related cancer is probably different from smoking-related cancer, but are there ways in which this is really different? So the rate of HPV-positive cancer, so OPSCC is oropharyngeal squamous cell carcinoma, those rates are actually increasing. So the yellow line here, I'm sorry, it's a little hard to see, is the overall rate of oropharyngeal cancer. This is from 1988 and 1990 up to about 2004. And you can see it's increased slightly. The gray line is HPV-negative oropharyngeal cancer. You can see it's decreasing. The blue line is HPV-positive oropharyngeal cancer. You can see it's rising quite rapidly, and that has only continued to increase. The survival rates in HPV-positive oropharyngeal cancer are also higher, which is really interesting. Why would a virally related cancer have better survival than a tobacco-related cancer? So this is a very standard curve that we see a lot in medicine. It's called a Kaplan-Meier survival curve. And basically it starts from a time point 0, where everyone is alive. And as time progresses here in months, so we're out to about 5 years at the end of this curve, you can see how many people are still alive. The dotted line is the HPV positive cancer, and the solid line is HPV negative. We can see at the end of 5 years, our HPV negative cohort has about a 60% survival rate, which is what it's been for the last 40 years. The HPV positive group, however, is up around 75 to 80%, and now I'd say that's even higher. We're looking at 5-year survival rates of upwards of 90% with HPV-related cancer, which is really exciting and fascinating. So why is this survival higher? We don't actually know. We have a lot of really good theories, though. So different patient demographics. This paper from a woman who's a head and neck cancer surgeon at Johns Hopkins. This is now quite, I'd say old, it's 7 years old now, comparing the characteristics of HPV negative and HPV positive cancer patients. You can see the age of HPV negative patients is slightly higher, and that difference is only exacerbated now. We're seeing HPV positive cancers in much younger patients, 40, 45 years old. The gender ratio, HPV negative cancers, 3/4 men, HPV positive cancers, 90% male. And the smoking history, HPV negative, 95% of patients have ever smoked, and of those patients, 95% of them have a greater than 20 pack year history, which means they've smoked at least 1 pack per day for 20 years. If we look at HPV positive cancers, 80% of patients are ever smokers, and this number has gone down as people have stopped smoking, and only 45% of them are heavy smokers. There's also some genomic differences. A lot of papers have come out on this recently, including some from a lab that I worked in at the Mass General Hospital. Tobacco exposure results in field cancerization, which is a term for the bathing of all of that mucosa in the carcinogens that are contained within tobacco smoke. So you have mutations in all of those cells that are slowly accumulating and eventually cause cancer. That doesn't happen in HPV. As far as we can tell, there's 1, maybe 2 cells that are the cell of origin for an HPV positive cancer. So they haven't accumulated all of the genomic mutations that we see in the HPV negative tumors. And this has been measured quantitatively by my lab, the lab I worked in, that looked at intratumor heterogeneity. So basically the cancer cells within the tumor, how different are they from each other? So HPV positive cancer, they're very similar, and I'll show you some data from that. There's also a thought that HPV positive cancer provokes more of an immune response from the host than the HPV negative cancer because those viral proteins are being expressed. There's a lot of work looking at, is this something that can be exploited in therapy? Potentially, could we have an HPV cancer vaccine? Maybe, people are working on it. So this is, you'll have to indulge me a little bit. This is from a paper we published technically this year, but data from a couple of years ago, looking at MATH, which stands for mutant allele tumor heterogeneity. All that means is it's a quantitative measure of intratumor genetic heterogeneity based on next generation sequencing data. So we obtained data that was genomic sequencing of different tumors. And next generation sequencing means you sequence those tumors over and over and over again. So you get sequences from a lot of different cells within the tumor. We calculate a MATH score where if MATH is high, that means that the heterogeneity in the tumor is high. If we do one of those Kaplan-Meier survival curves looking at low MATH tumors versus high MATH tumors, we see that the tumors with high heterogeneity have much lower survival than the low MATH tumors. And if we stratify that out looking at HPV status, we see that that holds true. So even in the HPV positive tumors, which we know are going to have much higher survival, if you stratify them into low heterogeneity and high heterogeneity tumors, we can still separate out the patient cohorts on the Kaplan-Meier survival curve. So this is really interesting. Maybe we could translate this into a clinical practice. We take a biopsy of a tumor, we do this sequencing. Maybe we can tell people ahead of time, hey, you have a low heterogeneity tumor. We think that's really great. Maybe we can decrease the amount of treatment you need. This is all a little bit pie in the sky in the future, but we're looking at, my PI is looking at getting this into clinical trials. So that's a little bit about the role of human papillomavirus. Papers are coming out every day. This is very much an evolving hot topic, at least in the head and neck cancer field. So treatment, everyone wants to know, okay, we know what head and neck cancer is, we know how we diagnose it, we know how we stage it, we know a little bit about its pathogenesis. What do we do about it now? So traditionally, and this is true for all cancers, there's 3 modes of therapy that are available: surgery, chemotherapy, and radiation. All cancers are treated with some combination of this. And the same is true for head and neck cancer. The choice of what that combination is really dependent on the tumor subsite. Are we talking about a cancer of the tongue? Are we talking about a cancer of the larynx? That's going to determine what our therapy recommendations are. It also depends on the patient characteristics. Maybe someone's very young and wants the best chance that they can have of survival, and they're going to do really well with surgery because they're young and otherwise healthy. Maybe we offer them surgery, where someone who has other medical problems, we would say, I think radiation is probably the best choice for you. So surgery, this is eventually what I will be doing someday, but surgery can involve complex head and neck cancer reconstruction. So in other places, it's very simple to, or well, not very simple, but it seems more straightforward to say, okay, you have a skin cancer on your arm. We can cut out an area that gives us good margins around that skin cancer, and you'll heal up great, and it'll be not going to cause you any trouble. Well, in the head and neck, there's some critical activities that go on in the head and neck. We talk, we eat, we breathe. All of these things are really important. So as we're treating these cancers, we have to keep those functions in mind because we want to preserve those functions as much as we can. So sometimes head and neck cancer surgery becomes very complicated because not only do we want to cut the cancer out, but we want to make sure the patient can eat, breathe, and speak afterwards. This is just an example of a cancer on the side of the tongue. To remove that cancer with adequate margins required cutting out about half of the tongue. Removing half of the tongue, you can imagine, makes it very difficult to do some of these things afterwards. So we reconstruct it with some tissue from the thigh, doing a microvascular free flap. And all that means is we take some tissue from the thigh that has its own blood vessels that we then hook up to blood vessels in the neck to allow that tissue to live and to increase function of the tongue. You can see here, this is just normal skin like you would have on your thigh. Once it's been in the mouth for about 6 months, it remucosalizes and looks almost just like the regular part of your tongue. It's not going to be the same, but some of these patients have really good outcomes. Not all head and neck cancer surgery is like that, but very frequently. Another important part of the surgery is looking at the lymph nodes in the neck. So one of the first places that head and neck cancer likes to metastasize to is the lymph nodes in the neck. So to treat that area, we do what's called a neck dissection. And this is really diagnostic and therapeutic. Diagnostic in that once we remove all of those lymph nodes and the pathologist looks at them under the microscope, we know exactly how many were involved with the cancer and where the cancer was. Therapeutic in that, well, now we've removed that first area that the cancer likes to spread to. And potentially if there are micro metastases or very small amounts of cancer in those lymph nodes, we've removed them now before they can spread elsewhere. There's a lot of different terminology related to neck dissections that really has to do with what levels of lymph nodes you're moving. So there's lymph nodes all throughout your neck. We only remove the parts that we think may be involved with cancer, depending on where the primary cancer site is. So these terms really just talk about how many of these levels we've removed. A radical neck dissection is something that was done very commonly, about 40 years ago. You'll still see these patients walking around. We've taken out one of the big muscles in their neck, one of the big veins, and one of the nerves that moves the shoulder. You can imagine that's a very morbid or it's an operation that has a lot of side effects afterwards. So we try not to do that anymore. Radiation therapy. So if you can't have surgery, you don't want surgery, surgery is not an option. Radiation therapy is really the mainstay for head and neck cancer treatment. This is a picture from a CAT scan. So this is axial slices. You can imagine bread loaf slicing through the head. This is the spine here. This is the jaw. And this is the planning that the radiation therapist has done in terms of which area they're going to direct the most radiation to. This is a technique called IMRT, or intensity modulated radiation therapy. Typical dose for head and neck cancer, 60 to 70 gray, which really translates to 5 days a week of radiation therapy for 7 weeks. This can be quite an ordeal for people. It's hard to get through. We tell them it's a marathon, it's not a sprint. Side effects, there's acute side effects that happen during the course of therapy, mostly related to inflammation and irritation of all of those delicate structures in the head and neck that are unfortunately also receiving some dose of radiation, no matter how carefully we plan it. So you get mucositis, which is just irritation of the mucosal lining. You get changes on the skin outside. It's very painful, you can have problems with thick secretions, and it makes you prone to infections. There's problems long-term too. So when you irradiate the salivary glands, they don't work as well, they don't produce as much saliva, you end up with dry mouth. Fibrosis, which is just thickening of the tissues of the neck and the jaw. Osteoradionecrosis is just a long-term breakdown of the bone and the soft tissues that happens due to the radiation. It itself can lead to a lot of pain, infections. Sometimes we do big surgeries on people, not because they have cancer that came back, but because they have side effects from the radiation that we're trying to treat. And you can lose your sense of smell and taste, and those are very important for kind of your quality of life moving forward. So these are all considerations that we take into account when we're discussing treatment options with patients. And lastly, chemotherapy. So for head and neck cancer, there's not really a chemotherapy that works very well. Most of the time, chemotherapy is used as a radiation sensitizer. So you get dosed with chemotherapy while you're undergoing your radiation because it makes the radiation more effective. Some terminology: induction chemotherapy is chemo that's given prior to the definitive therapy. This is rarely done in head and neck cancer because we've done several studies now that have shown that induction chemotherapy really doesn't gain us that much in terms of survival. Concurrent chemotherapy is the chemo that's given simultaneously with the radiation, and this we do very, very frequently. Adjuvant chemo is given after the definitive therapy. We hardly ever do this. And then there's chemotherapy that's given in the palliative or recurrent setting. So let's say you've had your chemoradiation therapy, the cancer comes back, it's not surgically salvageable, then maybe you would get some chemotherapy in an attempt to keep the tumor under control. The mainstay of chemotherapy for head and neck cancer is traditionally cisplatin, which is used for a lot of other cancers as well. We now also use carboplatin, which is a closely related chemotherapy. You can see here the toxicities related to these drugs, and they're not insignificant. So there is a fairly high risk of hearing loss with cisplatin treatment, anywhere from 23 to 50% of patients. That's much less with carboplatin. Peripheral neuropathy, or kind of permanent pins and needle feeling in your hands and your feet, again, can be very high with cisplatin, much lower in carboplatin. It can hurt your kidneys and cause bone marrow suppression, much less with cisplatin, but much more of a risk with carboplatin. So the oncologists we work with really say they spend a lot of time picking their poison. So which one do they think the patient's going to tolerate the best? There are some new and excited targeted therapies. They don't really deserve the term chemotherapy because they're not chemicals, but these are biological agents that are starting to be used in head and neck cancer. Cetuximab, which is an anti-EGFR antibody, where EGFR is an epidermal growth factor receptor. So this is a receptor on the cancer cells that when it is activated is driving them to grow. So this antibody blocks that receptor to prevent that signal from happening. Is the first new approved therapy for head and neck cancer in 45 years. It's been studied in randomized phase 3 trials. These are the biggest trials that we do. These are hundreds, if not thousands of patients randomized, blinded with the study therapy against the traditional therapy. And it shows that cetuximab really is synergistic in locally advanced tumors if given in combination with radiation therapy, in exactly the same way that cisplatin is. We've seen that there's no survival advantage when we give it in addition to cisplatin, but the trial hasn't been done yet looking at cetuximab with radiation versus cisplatin with radiation. That's a hard thing to get people to agree to randomize to. And then pembrolizumab is a brand new anti-PD-1 antibody. PD-1 is an immune checkpoint molecule. And basically that means that it's a molecule that's present on the surface of the cells that if it's present, tells your immune system, hey, don't bother me, I'm one of your own cells. Well, the cancer cells are very sneaky and express a lot of this molecule in an attempt to evade any sort of immune reaction against the cancer cells. So this anti-PD-1 antibody blocks that signal, meaning that then your immune system is free to recognize those cancer cells and help rid your body of them. There's been intensive testing in solid tumors, including metastatic melanoma, where they've had some fantastic results that unfortunately so far have been rather short-lived. There was preliminary data at the American, ASCO is the Clinical Oncology Society just this year, so 3 months ago, indicating that there's a higher response rate with pembrolizumab than cetuximab in locally advanced cancer. This is just preliminary data from an ongoing trial, but it's very exciting because at least to date, we've had nothing that has worked better than the existing therapies. Cisplatin's been around for those same 45 years that we've had a 60% survival rate for head and neck cancer. So that's very exciting. We don't have any idea yet if it's going to be long-term responses, but it's actively being investigated. So I mentioned earlier, head and neck cancer treatment is very much dependent on the patient, but also the subsite of the cancer. So this is by no means a prescriptive chart for how we treat these different cancers. But in general, if a cancer is in the oral cavity, meaning the tongue or the lips or the gums, the primary treatment is surgery. And mostly that's because if we try to irradiate that area, there's a lot of critical things, including your jaw, which is very prone to having serious problems with exposure to radiation. So we try to treat with surgery first, and then if needed, give chemo and radiation afterwards if there were not issues with the surgery, but if the surgery showed that there were bad characteristics of the tumor that made us worried that it was more likely to recur. Salvage therapy, meaning therapy that is available after recurrence, really is surgery. For the oropharynx, or the back of the throat, we typically start with radiation therapy and usually chemoradiation therapy because operating in this area is A, very difficult, and B, causes a lot of problems with those 3 functions we talked about, breathing, eating, and speaking. So surgery in that area, really not ideal. So we start with chemoradiation, no adjuvant treatment because you've already gotten the chemoradiation, and if we need to, salvage surgery. The hypopharynx, or the lower part of the throat, again, same issues with the oropharynx where it's a little bit tricky with primary surgery. The larynx is a little bit special. So for the longest time, primary treatment was surgery, surgery, surgery. There was a study done about 20 years ago now in the VA that actually showed that primary chemoradiation therapy gave equivalent survival to surgery in a certain subset of patients. And that swung the pendulum all the way back the other way to where everyone was getting chemoradiation for their laryngeal cancers. However, the larynx is a very delicate spot, and chemoradiation in this area does not always preserve those 3 functions very well. People can get chemoradiation and have big problems with speaking, swallowing, and breathing after treatment of their laryngeal cancer. So now it's very much dependent on exactly where in the larynx the cancer is, how the patient is already doing. So if you're already not breathing well because of your cancer, then we're not going to give you chemoradiation because you need surgery anyway. We're going to need to put a tracheostomy tube in so you can breathe. So this decision here is very center dependent and oncologist dependent. And again, salvage therapy is pretty much always surgery. There's a limit, a biologic limit to how much radiation you can give a person. Theoretically, there's a biologic limit to how much surgery you can give a person, but some surgeons may not agree. So consequences of treatment, and this is regardless of if you have upfront chemoradiation or if you have surgery. Again, head and neck, very critical. Feeding tubes, either temporary tubes or permanent tubes directly into the stomach. Breathing tubes, tracheostomy, or a stoma for this laryngeal cancer patient, where now all of the air that's going in and out of their lungs is coming through this hole in their neck. You can see this little tab right here, and that's attached to a tracheoesophageal voice prosthesis. And so we've removed the voice box in this patient. He no longer has vocal cords, but with this prosthesis in place, it allows air to pass between his esophagus and his trachea and allow him to achieve esophageal speech. So just because someone's had a laryngectomy does not mean they aren't able to speak ever. Not everyone can, but we do have things available to make this treatment a little more palatable. So we've talked about treatment, on to prevention. So how can head and neck cancer be prevented? Right here, stop smoking. So this is a chart. This unfortunately isn't head and neck cancer, but this is trends in tobacco use and lung cancer death rates in the US. And pretty much the head and neck cancer death rates mirror the lung cancer death rates. If we're talking about HPV negative, tobacco-associated head and neck cancer. The black line here is per capita cigarette consumption. This is 1900 to 2009, and you can see it peaked in the kind of in the 1955 to 1970 time period. This is the blue line is the male lung cancer death rate. You can see it's much higher than the female lung cancer death rate, and that's because men traditionally smoke at a much higher rate than women do. You can see there's a delay of about 15 to 20 years between the peak in the cigarette consumption and the death rate, because that's about how long it takes to develop cancer after you've smoked. But you can see it's happened with male lung cancer rate is already coming way down, and the female lung cancer rate, we've just probably seen the tip of it, and now that rate is coming down as well. This chart here is looking at different kinds of head and neck cancer, and you can see for oral cavity, larynx, and other pharyngeal cancer, the rates all going down between 1980 and predicted in 2025. The only one that's going up is oropharyngeal cancer, but that's because it's not related to tobacco consumption. Those are the cancers that are related to the HPV infection, so this is our increasing incidence of that cancer. By 2020, it's actually predicted that the incidence of oropharyngeal cancer will outpace cervical cancer in this country. So which brings me to the perennial question, vaccination against HPV. So I'm probably all of us have heard about the Gardasil and Cervarix vaccines against human papillomavirus. Initially created to prevent cervical cancer in young women. The vaccines are effective against preventing new infections, but are not effective against established infections or if you already have a cancer. So this is why the recommendation is that young girls and young boys are vaccinated so that you can get the vaccine before you're infected. All three of these vaccines target HPV 16 and 18, which are the very common high-risk strains of HPV. The Gardasil vaccine includes low-risk strains 6 and 11, and the Gardasil 9 has 5 additional high-risk strains, which really for head and neck cancer doesn't mean much. Something about 95% of head and neck cancers that are HPV-related are caused by HPV 16. So all three of these vaccines cover HPV 16. It's FDA approved, both of them for females, males for Gardasil only, ages 9 to 26, for prevention of HPV-caused anogenital cancers and warts. You'll notice head and neck cancer not on that list. The Cervarix trial, they did some data kind of with the patients they were following for cervical cancer and looked at HPV infection in the oral cavity. So not cancer, but just doing swabs and looking for HPV DNA in the saliva, and found that the vaccine protected against persistent infection. So we have no data that vaccination prevents HPV-related oropharyngeal cancer, but all of this is leading up to the idea that yes, it probably will. Unfortunately, it's going to take 20 or 30 years after the start of vaccination for us to have any data that this is true, because that's how long it takes for this cancer to develop. I think it's an important point, too, that there's no screening available for oropharyngeal cancer. So for cervical cancer, we have the Pap smear, where we take cells from the cervix, look at them under the microscope, looking for abnormalities associated with HPV infection and cancer. And that has greatly decreased the rates of cervical cancer in this country because we're finding all of the precancerous lesions and treating them before they can become cancer. This isn't available for head and neck cancer. People have tried and tried to develop the Pap smear for the tonsil, and that just hasn't happened. So vaccination may be really critically important for the prevention of HPV-positive head and neck cancer. Again, that is the only cancer, head and neck cancer, rising in incidence in this country. So in summary, these are what I really hope you remember going forward from here. Head and neck cancer, a heterogeneous group of tumors that are all treated homogeneously. So these cancers are all different subsites of the head and neck, HPV-related, not HPV-related, men, women, old, young, and they're all treated the same, some combination of surgery, chemo, and radiation therapy. We really should suspect head and neck cancer in a person with a persistent neck mass or unexplained pain. I'm not saying that everyone who has an enlarged lymph node for 6 weeks has head and neck cancer, but as clinicians, we need to think about it when we're seeing people, as patients, as advocates for your friends and family. Don't let everyone always tell you, no, it's not a problem. We see plenty of patients who come in who have had something going on for 9 months or a year, and finally, someone did the biopsy, and lo and behold, it's head and neck cancer. Head and neck cancer usually caused by smoking, but HPV-related cancers are on the rise. And the prognosis for HPV-negative tumors hasn't changed in the last 50 years, but luckily for us, HPV-positive tumors appear to have an increased survival for a lot of different reasons. And I'll take any questions now, and there's references in the back. I won't make you stare at them, but.
Thank you so much, Dr. Hammon. Wasn't that amazing? If I ever have an issue in this area, I want her on my team. Yeah, I totally want her on my team.
Oh,
thank you so much.
Yeah.
You know, I wanted to share this with you because we all know October is Breast Cancer Awareness Month, right?
Oh.
But the county of Los Alamos has made this proclamation and granted it to the Los Alamos Council on Cancer on behalf of you being here today. And so would you like to tell our audience what this says?
I may not get through it here. That the month of October 2015 is Head and Neck Cancer Awareness Month. So.
Right here in our community. So thank you to the county. Thank you to Los Alamos.
That's amazing. Thank you.
You're welcome. And so I just wanted to, again, thank Dr. Hammon for being here. There are white cards in your packets that if you have questions, we ask that you please write them down, and that might facilitate our time. And we have a couple of volunteers back here, board members, that are willing to take those and bring the questions to Dr. Hammon. Also, if you are here and in need of CEUs, please make sure that you fill out the appropriate paperwork and get that to us so we can get you the credits that you desire. All right, and so we've already got one question here for you.
Sure. My understanding of what happened to Joan Rivers. There's been a lot of gossip. So ENT is a very small specialty, and of course everyone knows someone who knows the person who was with Joan Rivers, but my understanding is that she was having an unrelated procedure to her head and neck, so something else entirely, and there was a question of some lesion on her vocal cords that an ENT surgeon thought they would investigate kind of in a space that wasn't equipped to do that. So not a lot of gossip, but I don't know any details, unfortunately. Okay, is squamous cell cancer more common in older age? So it is. So you can think of it as kind of an accumulating risk. So there's some, I don't know the number, but there's some risk per year that you'll develop squamous cell carcinoma. This makes sense if you think about the traditional causes. So if we're talking about the skin, squamous cell carcinoma of the skin related to sun exposure. The longer you're alive, the more sun exposure you have. If you're a smoker, the longer you're smoking, the more accumulated risk you have of squamous cell carcinoma. I think the key for tonight is that these HPV-related tumors are definitely occurring in a younger age group. So the published paper that I cited, the age difference in that group was only 4 years, but what we're seeing clinically is much different than that. So traditionally, we'll see people in their 60s kind of is about when we see the tobacco-related head and neck cancer. But for the HPV-related head and neck cancer, it's much younger. Again, we're seeing patients in their 40s even. And the common symptoms, again, neck mass, because again, those are going to be those metastatic lymph nodes in the neck, unexplained pain in the head and neck, ear pain even, because there's some common nerves between the ear and the back of the throat that if you have something going on in your throat can give you ear pain. And any trouble swallowing that's kind of persistent or changes in your voice can be an indication of laryngeal cancer. Good question. So the current percentage of young people who have been immunized for HPV, I don't know the number, but it's too low. It's too low. I think it's very dependent on the community you're in. I know some school districts are trying to make it a requirement as part of the required immunization schedule. There's been a lot of fight against that. It's a little stymieing to me because some of you may have seen my young son in the back there, 7-month-old Jamie. you know, there's a vaccine that prevents cancer. Like, why would you not get a vaccine that prevents cancer? But the immunization rates are very low, which is going to be troublesome trying to interpret data going forward in terms of decreasing rates of these cancers. So, testing for HPV at the time of a pap smear. So the recommendations of that on that have actually changed. I don't treat this area, but they do test for the particular strain, HPV 16 or 18. Cervical, so head and neck cancer, again, 95% HPV 16. Cervical cancer is a little different. It's more split between 16 and 18. I believe they test for the particular strain, but because it's more divided between the two, that's why all of those vaccines that they've developed include both of those strains. A question about the targeted therapies. Is this a growing area that might replace chemo? I think that's the hope. So, you know, cisplatin is a great drug for what we've had to use it for, but it's incredibly toxic, as you saw, risks to your hearing, peripheral neuropathy, your kidneys. The targeted therapies, by and large, have much decreased toxicity because they're targeted to specific molecules. We don't have enough data yet to just do away with cisplatin and only use cetuximab or pembrolizumab, but I think that's coming down the line. Is thyroid cancer a head and neck cancer? Technically it is, but it gets separated a little bit because thyroid cancers are cancers arising from the endocrine cells of the thyroid and are not arising from that squamous cell lining of the mucosa and the skin. So I didn't have an hour, unfortunately, is not enough time to discuss all of the different cancers that can arise in the head and neck. But thyroid cancer, definitely a head and neck cancer and treated by ENTs. Do I see cancer formed from, 1960s nasal radiation to reduce adenoid size? Oh, that's a good question. I think we have. Those are going to be more of the nasopharyngeal cancers, the squamous cell carcinomas in the back of the nose. I haven't seen any patients with this recently. We definitely see thyroid cancers from the, I forget what they're called. They were the shoe sizers that had the fluoroscopy. And the people who actually ran them in the shoe store, the way the box was constructed directed it right at their thyroids. So there's a lot of thyroid cancer related to that. We do definitely see cancers in the head and neck arising from previous radiation. I don't know about the adenoid irradiation, but people who have had Hodgkin's lymphoma, who have gotten the mantle radiation, which is radiation to the lymph nodes in the supraclavicular fossas, we definitely see head and neck cancers in those people that we can't prove, but we're almost sure is related to the radiation that they had. Head and neck cancer correlated with other cancer symptoms such as weight loss and night sweats. Weight loss, definitely. Part of that is just having the cancer. Part of that is cancers in the head and neck, when they get, especially when they get fairly large, cause difficulty with eating, and so people lose a lot of weight. Night sweats, not so much. That's a particular thing related to lymphomas and other blood cancers. Numbness in the mouth and lips, usually unilateral or bilateral. Does it follow cranial nerve paths? So squamous cell carcinoma does not, it can kind of track along the nerves. There are some other head and neck cancers that are much more rare, such as adenoid cystic carcinoma, which is a carcinoma that arises from some of the cells around the salivary glands that loves nerves. And you can see it on a scan. You have a small adenoid cystic that's just tracking all along a big nerve back towards the brain. We see that a little bit in the squamous cell carcinomas, and when we see this, it's called perineural invasion. It's kind of a negative prognostic sign in the pathology, and so if someone has perineural invasion or perineural spread of their cancer, that's another kind of checkbox that makes the oncologist lean towards giving them chemotherapy with their radiation or giving them radiation after their surgery. Does the anti-PD-1 antibody help for other autoimmune diseases? I don't know that they've tested it for autoimmune diseases. There's one interesting thing. Is that the one that gives the melanoma patients they lose all their pigmentation? I can't remember. I think that's the PD-1 antibody. So anti-PD-1, the pembrolizumab was first developed for metastatic melanoma. And because some of the patients who get this get such a robust immune response to their cancer, they can actually lose their melanocytes, or their pigment-producing cells, throughout their whole body. So hair turns white, no moles anywhere, like all of their skin, like they become almost albino because they lose all of those melanocytes. So you can get a very robust kind of general immune response. But for autoimmune diseases, in those cases, your immune system's already kind of hyperactive against something, so you wouldn't really want to release the checkpoint and kind of heighten that immune response. Is HPV just a sexually transmitted virus? So depends a little bit on your definition of sexual activity. We do know that HPV can be transmitted, it looks like, from oral to oral contact. So in someone who has HPV virus in their saliva, it looks like they can spread it to other people. It's a really hard thing to track. There's some epidemiologists out of Johns Hopkins who have done a lot of this really important work, and there's something like 8% of the population at any given time has HPV in their saliva in the back of their throat. And clearly, 8% of the population is not getting HPV-related cancer. So there's something else going on, that it's not just the presence of virus, but that genomic integration has to happen, plus some other things for cancer to develop. So depending on your definition of sexual activity, yes, just a sexually transmitted virus, but it looks like there can be some more innocuous forms of activity that can result in transmission. Oh, the time that, looking at the timeline between when symptoms arise and when people present to the doctor. So ideal is immediately, but we all know that doesn't happen. You know, a neck mass or a voice change, yes, that seems a little late, but you know, again, with the larynx, you can have a pretty small cancer on the vocal cord that can give you big voice changes, and those can be very early cancers that are treated very easily and have a high survival rate. You know, a lump in the neck, especially the HPV-related cancers, tend to metastasize early. So you can have a very small primary cancer in your tonsil or your base of tongue that has already metastasized to a lymph node in your neck, which technically increases your stage. So you may already be stage 4, and yet those people do very, very well with chemoradiation therapy and have a very high survival rate. So, you know, this is a really good question. So, you know, you have a cold, your voice gets a little hoarse. The hoarseness lasts for a few weeks. When do you start to worry? It's really hard to say. If anything else is going on, I'd say speak up sooner with your doctor. If you definitely had a cold and you're just a little hoarse and it's getting better every day, I wouldn't worry about it. The neck lumps, vast majority of the time, these are not head and neck cancer. It's just an inflamed lymph node that's kind of persisted a little while. I'd bring it to the attention of your primary care doctor so someone else can feel it. There's some characteristics about the nodes that makes us more concerned that they're cancer or not cancer. So someone else can keep an eye on it. I'd say if it's been a couple of months and it's still the same size or bigger, you have any other throat pain, definitely speak up to your doctor, get a referral to an ENT to have a more thorough evaluation done. Any other questions? Fantastic. Well, I'll be around for a few minutes, so if you want to come up, that's fine too.